Greetings and welcome to the GE-NMF Primary Care Leadership Program Colloquium on Social Determinants of Health. The moderator for this colloquium is Dr. Carol Freund-Taylor, Assistant Professor of the Department of Professional and Medical Education at Meharry Medical College.
Hello everyone. My name is Carol Freund-Taylor. I'm an Associate Professor in the Department of Professional and Medical Education at Meharry Medical College. Meharry has a strong commitment and a long reputation of producing primary care physicians who graduate and in great numbers serve the underserved throughout the United States. I'm very pleased to have this opportunity to have been a mentor for the PCLP summer students for the past 2 years, and now this year to moderate one of the sessions presenting student projects, specifically those looking at social determinants of health. Meharry is fortunate to have several investigators who are examining this problem of health disparities, which in great part tries to assess the impact of social determinants. My own graduate training is in human genetics, and even during that time long ago, as I was studying genetic factors of disease, it was clear that although genetics might explain some disease processes, there's much more to the story. And it's clear that human genetics has not changed so rapidly in the last 50 or even 100 years to be able to explain the explosion of obesity, cancer, and mental health issues that we see today. It's clear that social determinants of health are complex elements contributing to the development of, and most likely protection from, disease, but also the source of disparate health outcomes among different groups, whether you're identified by socioeconomics, ethnicity, race, or geography. Contributors to the medical literature have attempted to identify social factors and discuss their implications in health outcomes for many years. Leveraging the findings into change has been very difficult to implement, though. The locus of change is often placed on the individual and personal decisions, which is a notoriously stubborn rock to budge. Attention is now finally being paid to calling for systematic or structural changes, and arguably some changes are working. During this colloquium, we'll hear from 9 students who worked at 7 different sites this summer. They investigated the interaction of social factors with health in the context of their specific community health centers. Some directly compared their local findings to broader contexts to help inform the site and guide changes to improve care for the local patients. Others worked to inform individual patients about ways they can make their own changes to improve their health, and how clinicians can help in that process. They also, in the process, discovered some educational needs for the physicians.
Now we'll hear from our PCLP scholars who will each discuss their projects.
Hi, how's it going? My name is Tapera Chiwocha Jr. I am currently a student at Chicago Medical School, part of the Rosalind Franklin University of Medicine and Science. I'm currently in my second year of medical school, and I'm basically doing an MD program at the school right now currently. I did PCLP this summer that just passed. The place I was located at, the city was San Antonio, Texas. And the site that I was located at was Community Care Health Centers. And I would basically like to just go over my slide right here. So basically my project I did was looking at lifestyle awareness in health conservation. So different aspects that you could see in terms of diet, exercise, and self-perception. So basically what I wanted to look at was how to increase the patient's awareness to their own lifestyles, and whether patients were actually willing to make changes in their lifestyle behaviors that would affect their overall health. Then finally I looked at how the males and the females responded and compared their responses to see how they had different beliefs on self-perceptions of obesity And then overall, I just took that all information and was able to apply all the information that I took into how it overall affected the patient's understanding of health literacy. So the way I did it was I basically went to my health center, which was Community Care Health Centers, and I contacted each patient in person and asked them questions about each patient's risk for disease, how lifestyle has influenced their health, and overall small questions about aspects of their life that they were willing to change to better their health. The survey was about 10 questions long that I handed out to each patient. And after asking the questions to the patient and seeing their responses, I had educational information sheet that I would go hand to them and try to explain what was on it. Basically, the sheet explained overall the obesity and in respect to BMI, so basically how we consider a patient to be obese. And I basically asked the patient if they were interested in knowing this information. So basically the results that I found after doing this project was that females did tend to be more strict in terms of self-perception of their obesity than males, even though the BMIs and blood sugars were pretty much similar between the males and the females. Continuing, I found that the males were actually more willing to make basic lifestyle changes based off the results that I acquired. And then lastly, I looked at some recommendations that I would pass on to the health center or someone interested in furthering this research. So basically, if I think it would be helpful if there could be increasing a discussion on how to increase the patient's awareness of how their lifestyle can help to affect their health, and how they can make small steps to actually change their lifestyle to better their health. I think that males need to be educated in a more effective way on on whether they are overweight or not. And there might be some problems with the transmission of this information. And lastly, I just want to say that I'm glad to do this experiment because community care can definitely take this information and use it as a jumpstart tool to continue further research and understand the patient population in San Antonio a little bit better, and ultimately how the healthcare literacy is influenced in terms of the patient and how they understand what the doctor is trying to relate to them. And overall, in terms of just the whole experiment, I would like to thank PCLP for giving me the opportunity to do a project where I could work firsthand with the patients and work directly on an issue that impacts a large majority of the underserved community in the United States. I think that has made me a more grounded medical student, and I definitely have a better perspective of the diseases and issues that face a lot of people in the United States. So I'm grateful for that. Thank you. That's all I have so far.
Hello, my name is Ngozi Amuche. I am currently a second-year medical student at the University of Illinois at Chicago. This summer, I had the opportunity to complete my PCLP externship at the JWCH Institute, specifically at the Center for Community Health, also known as the CCH, which is located in Skid Row, Los Angeles. Skid Row is the homeless capital of the United States, with a population of about 18,000 homeless individuals at any given time. As I mentioned, my site CCH is located in the heart of Skid Row, thus the majority of patients seen there are homeless. Prior to arriving in Los Angeles, my site mentor, Dr. Paul Gregerson, informed me that the CCH has recently been experiencing a downward trend in preventative health screenings, specifically in pap smears, mammograms, and colon cancer screenings. Bearing that in mind, I decided that the purpose of my project would be to assess the specific challenges and barriers faced by the homeless patient population at the CCH in receiving preventative care. I carried out my project using a three-part process. The first part of my project involved doing one-on-one interviews with 30 patients at the CCH to assess their regular source of care, their thoughts and beliefs about preventative care, as well as their perceptions about the barriers they face to accessing care. The next part of my project was one-on-one interviews with the 6 providers at the CCH, and I asked them questions that would help me understand the providers' beliefs about the challenges their patients face in receiving preventative care, as well as the challenges the providers themselves face in rendering preventative care. And then also I wanted to hear any suggestions they had for improving this downward trend in preventative health screenings at the CCH. Finally, I did a comparison between the patient's beliefs about the barriers they face versus what the providers said they thought were their beliefs about the barriers that patients in accessing preventative care. From my study, I found that the top barriers the patients at the CCH face in accessing preventative care include 1. Unstable housing, 2. A lack of transportation, and 3. Difficulty that they face in making it to referral appointments that require them to go outside of the CCH. I also found that the providers share many of the same beliefs as the patients about barriers to care. So the providers are pretty well aware of the challenges and obstacles that their patients are facing in accessing care. After conducting the interviews and observing, as well as being a part of the daily ongoings at the CCH, it became very clear to me that much of the responsibility for making sure that the patient's health is well managed really falls on the providers. As you can imagine, the patients at the CCH face so many obstacles in their daily lives that managing them to fall very low on their priority list. That being said, most of my recommendations, all of my recommendations actually, are geared toward the healthcare team at the CCH rather than toward the patients. That being said, my final recommendations for the CCH to improve the downward trends in preventative health screenings are to first maximize resources available to them through the electronic health record. The electronic health record used at the CCH is called NextGen, and it actually has the ability to electronically generate flag reminders that will alert the providers when a patient is due for health screenings. This way, the providers will be less likely to get so wrapped up in the actual visit that they forget to take care of health maintenance. Also, I believe that preventative care needs to be made a priority at the CCH. This means that every person on the care team, from the medical assistants to the nurses to the providers, need to be completely aware of their responsibility in the process of rendering preventative care. So if the providers are responsible for actually ordering the preventative health screenings, then someone else on the team needs to take on the responsibility of following through with the patients and making sure that the patients are actually completing the health screenings. So someone needs to take on the responsibility of actually inputting the results into the system to keep the electronic health records up to date. Overall, this was one of the most eye-opening and amazing experiences that I've ever had. The biggest lesson that I learned from being at the CCH and working with Dr. Gregerson and interacting with the patients was how important and crucial it is that providers take the time to truly understand the needs of the patients that they serve and really make sure that the way that they render care caters to those needs. I'd like to end my presentation by giving a special thank you to my mentor, Dr. Paul Gregerson, as well as the entire JWCH Institute. I'd also like to thank General Electric and NMF PCLP for making this opportunity possible. And thank you to you all for taking the time to listen to my presentation.
Hi everyone, my name is Christina Feeney. I'm originally from Trumbull, Connecticut, and I'm in school at Rutgers University as a PhD student. This is my third year, so I'll be graduating in May of 2014. I was placed in San Antonio, Texas for 6 weeks this summer working at CommuniCare. And as we all know, exercise is something that patients are really lacking in their life. So our objective for my study was to determine the significant perceived barriers, including personal, environmental, and social, for the patient population at CommuniCare Health Centers in San Antonio, Texas, for those patients with chronic illnesses. What we did was made a questionnaire which was distributed to patients with chronic illnesses between 18 and 75 years old that assessed their height, weight, whether or not they met the CDC physical activity guidelines, if they wish to be more physically active, in 10 different possible perceived barriers. The data was then stratified based on age, gender, and BMI. The key findings we found was that pain was the most common perceived barrier for all patients, regardless of their age, gender, or BMI. Lack of motivation and lack of skill were the other two most common perceived barriers. 62% of those that were obese rated pain as a barrier, compared to only 27% of the non-obese patients. On average, patients reported 2.57 barriers. Those that met the CDC guidelines of 2.5 hours of physical activity reported 2.38 barriers, and those that did not meet the guidelines from the CDC on average had about 2.8 barriers. In conclusion, we recommended that healthcare providers should really set goals for their patients, challenge them, and make sure to follow up with their progress. The healthcare providers must address chronic pain for each patient and treat them accordingly. It's also important to involve a professional that can focus on physical activity, like a personal trainer, which may entail reaching out to outside organizations to refer patients to, educate them on various exercise, and individualize their exercise regimen. Research does show that group-based education courses and exercise classes have success. It's also important to have an interprofessional approach, having many different professionals from healthcare. Research also shows more success in focusing on one aspect of a patient's life at a time and on the improvement of their quality of life, rather just on weight loss and chronic disease progression. Overall, I had a really great experience living in San Antonio. I think it was great to see how healthcare and how patient populations change depending where you are in the country. From this research specifically, I think once I'm practicing as a PA, I definitely will make sure to focus on increasing exercise in patients and keeping in mind that each patient is different, and it's important to focus on why they're not exercising and to see how they can overcome those barriers. Thank you so much and have a great day.
Hi, my name is Amanda Leland, and I'm a third-year medical student at the University of Louisville School of Medicine. I was placed in Jackson, Mississippi at the Jackson Hines Comprehensive Health Center. I decided to do my project on mental health stigma and the need for mental health resources in Jackson, Mississippi. This was a very relevant project because Jackson Hines is opening up a new mental health facility at one of their new clinics. So it was really important to learn more about the community's views on mental health and the needs for mental health care. We decided the best way to measure how the new facility could provide better mental health care would be to do a survey, and it had 45 questions that were either read aloud and filled in by the reader or were filled out individually by patients. In the end, 139 patients filled out and completed the survey at various clinics, so it was a pretty good measure in diversity of patients. The results were really interesting just because the stigma was not as severe as we originally thought it would be. In fact, 90% of patients felt comfortable talking to their primary care provider about their mental health, and 66% said that they gained most of their information about mental health from their providers. So this was really interesting, especially since only 40% reported being screened for mental health and substance abuse issues. And this is a very shocking percent because a good number of these surveys were filled out by patients visiting social workers, so specifically for mental health and substance abuse issues. So this number was probably even lower in the primary care setting. And this provided some good information for Jackson Hines because with these new resources available, it's really important for mental health to be brought up in the primary care setting so that individuals can get the care that they need. It's also important for providers to realize that mental health is a very important part of primary care, and with a comprehensive health center, it should be included just like dentistry and ophthalmology and all the various forms of primary care in the patient visit, something that should be screened for. So what was really interesting is that instead of needing to educate the community more about mental health and providing better resources that way, it was the providers that needed more education and a better understanding of the role of mental health in primary care, especially since an individual with diabetes, if they have depression, may be less motivated to be involved in their care and follow through with their care. I also think it's important to realize that since most individuals gain most of their information about mental health from their providers, that mental health resources should be made readily available in the patient waiting room or in the patient's room in general. So this was a really great project for me. I learned a lot, and I really enjoyed my time in Jackson, Mississippi. Thank you.
Hello, my name is Norhan Muhammad, and I go to the School of Sophie Davis School of Biomedical Education. I'm currently a fifth-year student, which is a second-year medical student equivalent because my program is a BSMD program. So you start straight out of high school and then you kind of go into your medical school courses really quickly. My city placement this summer was in Nashville, Tennessee, specifically at the United Neighborhood Health Services clinics. And what I wanted to do this summer was work on prevention implementation and create something that would be sustainable even after I left. So I know that a big problem in Tennessee is obesity, and there's a lot of diabetes and heart problems. So I believe that like a lot of these diseases have an underlying risk factor of obesity, and obesity can basically be prevented if we were to use proper prevention measures such as education and telling our patients about how to eat healthy, how to get proper exercise, and basically giving them the access to these resources. So while I was doing my project, I was compiling a couple of statistics, and I think a lot of my key findings were a little surprising. So Tennessee is ranked as the state with the 17th highest obesity rates. In Davidson County alone, which is where I was placed, 37% of the population is overweight or obese. Over 50% of the restaurants serve fast food, so that's not just 50%, it's over 50%. So you can imagine that people really rely on fast food to get their nutrients, which can sometimes be very high in calories. So many people are just literally packing on the pounds without even realizing it. 70% of adults in Davidson County report having less than 5 servings of fruits and vegetables a day. So if you're not having fruits and vegetables, you're kind of at a disadvantage because you're not getting the healthy nutrients and you're not staying fuller longer. So you're going to go to other fast food restaurants to kind of get what you need. And just in general, obesity has been linked to the increased consumption of fast food by Americans, and this can be due to many factors. Now that we are very machine-based and technology in the world around us is changing very fast. As Americans, we have to adapt. So we say, time is money, and we don't spend a lot of time just being lazy and stuff. So a lot of times the only way you can fit nutrition into your lifestyle is by just going past the McDonald's or Dunkin' Donuts and picking up something really quick. Also, during 2007 to 2010, fast food was consumed the most by adults aged 20 to 39, so that is definitely the age range where people really start to get into their jobs, and there's the stress of life that kind of hits that time. Also, non-Hispanic blacks and the obese, obviously. So it was interesting to find that there were non-Hispanic blacks because that's actually the population that I was working with. And to implement a prevention practice that would be sustainable would have been very beneficial for United Neighborhood Health Services. So my idea was to create a nutrition video that basically went through how to read a nutrition label on a particular food so that people actually know what they're consuming, so they don't think that a bottle of Coke is only 50 calories, whereas that bottle may have 3 servings, so it's actually 150 calories. So just to educate them on how to read a nutrition label. The second aspect of the video covered fast food versus healthy food and making it at home. A lot of people think that fast food is cheaper and it's the fast solution. While it may be the fast solution, if you look deeper into price comparisons and how much it really takes to make a burger at home versus buying it from McDonald's, you'll find that preparing your food at home, although might take a little longer, actually saves you much more money in the long run. And the third aspect of the video talked about healthy substitutions. So instead of going for 100% fat, go for 1% fat milk, kind of along those lines for the dairy products, going for whole wheat instead of the white grains, because whole wheat can be more beneficial, has more nutrients, and also keeps you fuller longer. So the video just kind of covered various aspects of healthy nutrition and kind of how to get yourself to eat healthy and be aware of what it is you're actually putting in your body and what poor nutrition can actually lead to. And we all know that we're in an era of heart disease, stroke, and diabetes, which are all chronic diseases that virtually can be eliminated with proper primary care and prevention. And um, really, at the end of the day, if we have strong primary care, then we have strong prevention. And I hope that by creating this video, people can be watching it in the waiting room and they can kind of ask their physicians when they see them more about the video and basically educate them on how to live healthier and longer and be more aware of their nutrition. So thank you.
Hi, my name is Kelsey Murray. I'm a second-year medical student in the MD program at The Ohio State University College of Medicine. My site was Franklin Primary Healthcare Center in Mobile, Alabama. My project is entitled Survey of Mental Health Needs in a Primary Care Setting. My objective was to complete an assessment of the mental health needs of adult medicine patients in a primary care setting and to survey providers' thoughts on mental health issues in preparation for a new behaviorist coming to Franklin who will be integrating into primary care teams. To achieve this objective, I had 3 methods. First, I created a patient mental health screen from a standardized mental health screen, the Patient Health Questionnaire, or PHQ, and I pared this down to a few key questions for each major mental health issue. Surveys were handed out to all adult medicine patients seen by a specific nurse practitioner over 1 week for a total of 58 screens. Secondly, I created a provider survey to better understand their thoughts about mental health and integrated care. 6 providers returned my survey. I also observed behavioral health care and provider teamwork and flow at Franklin. The graph at the right indicates the results from my patient survey. Patients had a wide variety of mental health issues and concerns. 17% stated that they had a mental health concern that day. 23% scored positive for a depression screen. 19% scored positive for an anxiety screen. 10% scored positive for a bipolar screen. 29% reported eating issues. 42% had problems with too much, too little, or poor quality of sleep. 15% scored positive for a PTSD screen. 40% smoke. 8% are high-risk drinkers. 8% have used an illegal drug or prescription drug for non-prescription uses. And 23% said that these issues have made it somewhat difficult or extremely difficult to carry out their activities of daily life. Addressing mental health will improve physical health and well-being and will lower medical costs and complications in the long run as patients are better able to deal with their health issues. From the provider screen, for the most part, providers feel like they address mental health concerns, but they do admit that they don't always have enough time or training to do so. In addition, the majority of the physicians express feelings of burnout. I also observed that integration of mental health and primary care would be feasible and useful at Franklin in their team model. I have several recommendations based on this project. First, I recommend that all patients be screened for tobacco use, sleep issues, overeating, depression, anxiety, and PTSD, either through a paper screen or through the nurse or MA initial check-in. I also recommend that providers address general mental health, mood, motivation, and stress issues in chronic care visits that may be affecting their physical health. In addition, I recommend that Franklin integrate behaviorists into the primary care team, as they are planning to do in the near future, to follow up on positive screens, address issues, set goals with patients, and help patients get connected to community mental health resources. Lastly, I highly encourage Franklin to provide education and support for providers regarding their own mental health and burnout, and make sure that providers know that Franklin cares about their mental health. In conclusion, patients have a variety of mental health needs and concerns that can be screened for and addressed in primary care, and would be aided by the integration of a behaviorist into the team. In reflection, I learned a lot about the challenges to providing quality mental health care, especially in an underserved setting. In addition, we found that many patients' physical health needs might improve if their mental health issues were addressed, and this provides incentive for primary care to address mental health needs. I hope that Franklin will provide the necessary support and training for integrating mental health needs into visits and behaviorists onto the team, and will continue to care for providers' own mental health and well-being. Thank you for your attention, and I hope you learned a little bit about the mental health needs of a primary care setting, as I did.
Hello, my name is Stephen Richmond, and I'm currently a second-year medical student at the David Geffen School of Medicine at UCLA. This past summer, I had the honor and privilege of being a PCLP extern at the Jackson Hines Comprehensive Health Center in Jackson, Mississippi. Please enjoy the next few minutes as I share my summer project with you. My project was entitled Way Forward, Achieving Healthy Weight Goals in Underserved Communities. The goal of this project was to understand the problem of obesity in the Jackson Hines patient community, and also to propose a feasible and effective alternative to the potential ineffective weight loss interventions. To characterize current weight loss interventions, 2 separate 10-question surveys were administered. One was given to clinical providers and one was given to patients. Subsequently, a weight loss workshop and a workshop evaluation were conducted. After completion of the surveys and the evaluations, results were compared, tabulated, and interpreted. Key findings from the study were as follows. The majority of provider respondents said that they were counseling patients, giving patients educational information, and discussing the benefits of weight loss with them. However, less than half of the respondents were helping patients to develop a diet and exercise plan. This is critical because clinical studies comparing planned weight loss against unplanned weight loss programs suggest that planned interventions are indeed more effective at achieving weight loss goals. These data verify that there is a significant unmet need within the Jackson Hines patient community. Moreover, both provider and patient surveys tell a story of a patient population which is the majority overweight or obese and in need of more intensive long-term interventions. To remedy this, I conducted a weight loss workshop, which was designed to teach patients to eat healthy, to exercise healthy, and inform them of the risk of obesity. Key findings from the workshop evaluations are as follows. Patient attendees scored 69% on the 5 diet questions, 76% on the 5 exercise questions administered before the workshop. Patient attendees scored 89% and 91% respectively on the 5 diet questions administered and the 5 exercise questions administered after the workshop. These data show that the workshop or a similar intervention could be more effective than current provider strategies to help patients reach healthy weights. Considering the findings from this study, it is my recommendation that the Jackson Hines organization implement an intensive workshop and/or weight loss program, as well as an outcomes-based feedback system for the better health of their patients. In conclusion, the Healthy Weight Project was a needs assessment, characterizing the current weight profile of patients in the JHC patient community, in an effort to determine the feasibility and effectiveness of a workshop-style intervention. It will hopefully serve as a starting point for future endeavors of this accord. Data collected from the patient and provider surveys, as well as the Healthy Weight Workshop, demonstrated that Jackson Hines patients are in need of greater, more intensive interventions to facilitate weight reduction. Both Jackson Hines patients and staff are poised to accept such interventions. On a personal note, this was a great opportunity for me to confront real problems in the underserved communities. Additionally, it helped me to modify, to codify, and to clarify my interest in being a community health center provider in the future. I hope that you enjoyed this presentation as I enjoyed sharing it with you. Thanks for listening.
Hello, GE, NMF, PCLP scholars and faculty. My name is Darabel Tavares. I attend the Sophie Davis School of Biomedical Education in New York City. This summer, I completed my 3rd year of my BSMD program, which translates to the 1st year of medical school. I had the privilege of being placed at Franklin Primary Health Center in Mobile, Alabama. The objective of this project is to teach Franklin Primary Health Center not only why self-management goals are important, but also enough information on how to implement different techniques to create successful self-management goals among patients and providers. Self-management goals can be utilized to alleviate issues revolving chronic conditions. Therefore, before providing Franklin Primary Health Center with example models on how other medical providing practices in the nation use self-management goals, it was first necessary to show why Franklin Primary Health Center needs this technique. This was done by collection analysis of data on 3 chronic conditions of adult patients over the age of 18 among all 15 centers at Franklin Primary Health Center. These three chronic conditions were smoking, obesity, and diabetes. When comparing Franklin Primary Health Center to the national benchmark in 2012, the results showed the prevalence of smoking at Franklin Primary Health Center was 30%, while the national benchmark was at 14%. The prevalence of obesity at Franklin Primary Health Center was 38%, while the national benchmark was 25%. The prevalence of diabetes at Franklin Primary Health Center was 17%, while the national benchmark was 11%. Smoking, obesity, and diabetes are chronic conditions that can be better improved by self-management goals. Anything from increasing exercise to a change in diet can help with the three chronic conditions analyzed in the study. Since all three conditions are well over the national benchmark for Franklin Primary Health Center, the opportunity to change the lives of the patients at Franklin Primary Health Center is possible. 3 examples on how self-management goals can be implemented at the center are: number 1, hiring a health educator; number 2, hiring a health coach; and number 3, encouraging patients to take their health into their own hands through patient activation. Health educators and health coaches are counselors who assess the confidence and readiness in patients to help them change their habits into healthy opportunities. This is done by a constant relationship between patients and their health educators or coaches to set realistic goals, identify barriers or relapses, and find resources amongst the community to aid them in achieving their goals. It is the job of the health educators and coaches to make sure they provide enough advice, assist in developing an action plan, and arrange follow-up communication with the patient. However, the point of a health educator or coach is to teach the patient how to make their own decisions and only receive help from their educator or coach versus commands. This is similar to the last model, which is a relationship between physician and patient that is more collaborative than traditional. The physician, like a health educator or coach, works with their patient as a team. The patient guides the physician through their pain, problems, and life. The physician steps back and shares responsibility for the patient's health by teaching them problem-solving skills that can aid them with the goals they want to set for their health. However, the physician does not simply give instructions. This kind of care, which forces a patient to be more proactive, can only work if the physicians can adequately activate their patient, which is why a questionnaire for patients about the responsibility of their health before visit is a helpful start to changing traditional care to collaborative. Once patients are better able to help themselves with their chronic conditions, they can turn to helping the community. However, it is the role of the physician to provide their patients with the confidence and skills necessary for changing their health. It has always been a belief of mine that the opportunities to change one's health can be made realistic if the right resources present themselves. Community health centers have 2 great resources: their patients and their providers. When patients and providers combine their expertise by filling in the gaps for each other, they can make achievable goals to start a movement which improves the health in their community. Thank you so much.
So, these were 9 important projects, and they all investigated various elements of social determinants of health. Some explicitly sought to identify barriers confronting individuals and clinicians from achieving good health, while others compared barriers reported from studies of other settings to the situations faced by the community at their sites. The key themes that emerge from this set of projects surround changes that the patients need to make and how the clinicians can best support those changes, as well as the needs that the clinicians and sites themselves have to meet in order to best serve the community. Components of each of the 4 kinds of social determinants, environmental factors, knowledge, nutrition, and interventions that have been identified in these projects, and suggestions have been made. Patients need increased knowledge in order to make good choices about food and activity. Improving personal action about these areas can help patients to reduce obesity and, we expect, the host of other attendant ailments that follow. Identifying personal barriers to making good changes will help physicians initiate a conversation to begin to address the problem. Physicians, though, need training, education, and time to help support their patients in understanding the information and integrating it into good lifestyle choices. Several projects recommend additional members of the healthcare team who could help with these education and support processes. Education materials for the patients, such as brochures and waiting room videos, as well as materials for physicians, which include reminders of healthy ranges for various tests or other talking points, have been developed for use at some sites. Barriers that confront physicians that were uncovered really boil down to time available with the patient and also many topics that need to be covered with each patient. Providing reminders for physicians to carry out mental health screens as well as other health screens is proposed as a way to hurdle a barrier for patients to obtain services for care and health issues that may remain hidden. Physicians and site director awareness of what barriers already exist for patients and which barriers are more of a problem for which patients, such as where services are available or even what the facility may be called, can help to facilitate appropriate changes to lower those barriers, allowing better care for all. Interestingly, a theme emerged in several projects about the role that electronic health records play or may play in improving healthcare, and presumably improving patient health. At locations where the EHR is already in place, data collection was easier for the students, and some proposed built-in screening reminders, and therefore those could be feasible in those EHRs. In other settings, the transition to EHR is just still underway, and while the transition may be new, and although hopefully brief barrier, we can overcome that. Overall, I believe that the students learned a great deal about how to be a primary care physician, especially for underserved communities. I expect these experiences will make them more aware of patient needs throughout the rest of their training, as well as improve the kind of care that they provide when they are directly on the front lines. I hope that they have gained substantial insight into the complexity of the problems that are faced in the community setting, as well as insight into what it takes to predict the impact of changes, and how to go about bringing good changes to effect. The discussion questions that come to mind are really about integrating your summer experiences with the current changes that are in the air in healthcare. First of all, what impact do you expect for the patients at your site following the implementation of the Affordable Care Act? So address this with specific respect to the health question that you looked at for the summer. Similarly, what impact do you expect for the clinicians at your site following the implementation of the Affordable Care Act? And this is going to be not just the physicians, but the other members of the healthcare team. Many of you mentioned other members of the healthcare team that either could be recruited to participate or could be hired to participate. So think about some of those things as well. And then the third question is, what is the most important next step for the healthcare team at your site to do in order to follow through on your project findings? Most useful would be to identify a specific action, not a vague description, but some specific action that could be done, or a couple of actions that could be done for them to make some good changes. So thanks very much for all of your presentations, and I look forward to hearing about your discussions.